start our pathology conference. And you have we'll move over with Behzad Najafian, and some interesting cases coming from both Christopher Blosser and Sarah Sangavi. So,
thanks, Daniel. Good morning, everyone. So let's start the pathology conference. First with this workplace, I want to make sure that everything is working. So, okay, I can share my screen. That part is good. And Daniel, do I need to do anything different? I can see the annotation here now, which is good. And I hope that everyone can use the tools.
Yeah, I think everything should be a go.
All right. Perfect. Let me just put that on the presentation mode. Okay. How does it look now?
Looks perfect.
All right. Okay. So let's start the biopsy conference today. The first case is a complicated time zero biopsy, and Dr. Blosser is going to tell us about the clinical history of this case. Chris?
Thanks, Behzad. Great talk by Karen. It's fun to follow that with something hopefully also interesting. So I care for this 67-year-old male who came to transplant with type 2 diabetes, well-controlled, hypertension, obesity, and end-stage kidney disease. He started PD in January of this year, and when he was called in for his transplant was making about a half a liter of urine per day, and his UA on the day of transplant included 2+ protein, 2+ glucose, and 3 to 5 RBCs. He consented to receive a deceased donor after cardiac death from the 66-year-old male who had cardiac arrest associated with fentanyl overdose, which we're unfortunately seeing all too often now. Patient had previous sepsis, hypertension, type 2 diabetes, and was hepatitis C positive. That all resulted in a KDPI of 88%. The cold ischemia time on this kidney was about 24 hours, and warm ischemia time on the higher end at 49 minutes. The recipient had a PRA of 13%. Thankfully, the cross-match was negative, and we went ahead with induction with ATG, steroids, myfortic, followed by tacrolimus. You'll note that his CMV and EBV were both positive, and Hep C, HIV, and hepatitis B were all negative for the recipient. Thank you.
Okay, thanks, Chris. So, typically, after the clinical information is done, I ask that what's your differential, but this was a time zero, right? So, and we didn't know actually about the clinical history until afterward. The only thing on the biopsy slip was that it's a time zero biopsy. So here it is, and we're looking at this time zero biopsy. At the first look, well, it doesn't look very great, but it's not terribly bad either. So it's a portion of cortex, 16 to 18 glomeruli. As you can see, there are some areas. This is methylamine Jones methylamine silver stain, right? So areas that have more collagen and fibrosis, they look more black. So in these areas, we have focal interstitial fibrosis and tubular atrophy. Well, in the subcapsular area, sometimes we have more chronic injury as well. Also, we have a couple of subcapsular inflammatory infiltrate. And let's look closer. This is the periodic acid Schiff stain. At the tubules, well, very common thing that we see in the time zero biopsies is acute tubular injury. And actually, this one, it wasn't terribly bad at all, but still we had that. So as you can see, the more kind of normal proximal tubule should look like this. And in the, excuse me, in the middle, we should see like brush borders stained well. And for comparison, here in the neighborhood, we have some proximal tubular cells with partial flattening of epithelial cells and also loss of brush borders, variably seen, and chronic injury. Okay, still, it's not really that remarkable at all for a time zero biopsy. And this is a glomerulus. First look, maybe it doesn't look terribly bad, but what do you guys think? How do you describe this glomerulus? So you could put a check mark in front of any of these that you think are remarkable. Mesangial hypercellularity, mesangial expansion, membranous nephropathy, and you can have more than one choice, for sure, or thrombotic microangiopathy. Okay. All right, see mesangial expansion, some mesangial hypercellularity, and I agree. I mean, a little bit. I mean, it's quite mild though. It's not that severe at all. I mean, normally the mesangial regions are maybe like this, are thinner. Here it looks like a little bit more expanded. Is there mesangial hypercellularity in this particular glomerulus? It would be difficult. I mean, as you know, we call it when we have more than 3 nuclei, so like 4 nuclei or more in one of the mesangial segments. It's hard to find something like that in this particular glomerulus. Now I'm moving to this other one that is stained with Jones methenamine silver. I don't know if you want to change what you said before or not. For me, I would say that yes, still maybe a little bit of mesangial expansion, right? And in this segment, I can count more than 4 nuclei, maybe 5. So there is some mesangial hypercellularity. I agree with that. Glomerular basal membranes, they look fine, right? So still, I mean, really not that remarkable. The mesangial regions may be a little bit more eosinophilic material, which in this glomerulus actually is a little bit more prominent. So when I looked at this, said, okay, it's not as normal as it should be. Let's wait until we look at immunofluorescence microscopy, right? Okay, so far, a little bit of mesangial expansion, focal mesangial hypercellularity, glomerular basal membranes, they look fine. And this is that area with mesangial expansion and a little bit of eosinophilic material. And now this is immunofluorescence microscopy. So as you can see, we have IgG, modest staining, maybe 1 plus or 1 to 2 plus at most. Mesangial IgG staining with C3 a little bit as well, maybe traced to 1 plus, C1q similarly, traced to 1 plus. IgA and IgM were negative, fibrinogen was negative. Kappa was negative, and lambda was similar to IgG. So that was kind of a surprise. So it looks like we have deposits that are staining for IgG lambda. Okay. And when we look around on the slide for immunofluorescence microscopy, we notice that besides the bias of light chains, so no kappa, and we have some lambda staining. Also, there is relative bias. It wasn't absolute bias, but there was relative bias in the cast as well. So that and of course, this is a time-zero biopsy, so it's expected that still what we are seeing is coming from the donor, mostly coming from the donor, at least. So there was something maybe in the donor that we did not know about. So we got excited. But at that point, what is your differential diagnosis given this information that I gave you? And again, you can put as many marks as you want. So lupus nephritis, proliferative glomerulonephritis with monoclonal immune deposition disease, PGNM-ID, primary amyloidosis, fibrillary glomerulonephritis, immunotactic glomerulonephritis, cryoglobulinemic glomerulonephritis, HCV-related immune complex GN. The donor had HCV, was HCV positive. So I hope that the annotation marks are still working, okay? PGNM-ID, okay, so because we have IgG lambda or primary amyloidosis. So we have IgG and we have lambda, so maybe it's light and heavy chain. Deposition disease, fibrillary glomerulonephritis, most of them are polytypical IgG, but yes, in a small fraction of them, we have monotypic as well. And immunotactic glomerulopathy, that is more commonly associated. So all of those are really good thing. Nobody thought about HCV related to immune complex GN or cryo, because for cryo we didn't have MPGN. Okay, all right. I would say that this is very reasonable thought. So let's look at the electron microscopy. So how can I clear? Should I do erase there, or do I want to clear the marks? There should be an easier way, right? Okay. So now let's look at the. Okay, thank you so much. So let's look at the electron microscopy as well. All right, so there are some changes. I mean, we had corrugation of the glomerular basement membrane. I'm walking my laser point over the glomerular basement membrane. So there is some corrugation, and also there is some thickening. And we heard that it looked like the donor also, I mean, at that point, well, at this point, I think that we had some information for EM. So had diabetes. So maybe part of that is coming from that. Also, this is mesangial matrix. There is some expansion of mesangial matrix. Okay. But when you, and podocytes, by the way, I mean, let me show you that the podocyte also shows significant widening of the food processes, significant effacement of the food processes. Okay. I mean, certainly not a normal time zero biopsy in terms of electron microscopy findings. And, but look at this region. It looks like that the glomerular basement membranes are kind of dirty. Is that because of a lab issue and artifact or not? So let's look closer. Some delay. Okay, here. So this is a higher mag view of the same capillary loop. So thickening of glomerular basement membranes, increased mesangial matrix, expansion of lamina interna. But look at that. I mean, these densities that we saw are actually more widespread, partially looking a little bit powdery, but also when you look at them more carefully, you see that they are kind of like fibrils in the glomerular basement membrane, and maybe vaguely in the mesangial regions as well. So now let's look closer. I think that we can see some fibrils. They are not very well defined in this region of the glomerular basement membrane, but certainly we can recognize that there are some fibrillary structures in the glomerular basement membrane. So it's very interesting. Let's look at other areas of the glomerulus. Again, similar findings in terms of thickening of the glomerular basement membranes, some expansion of the mesangial regions. But as you can see, I mean, even when looking at the mesangial matrix, looks like they have the same heterogeneous appearance that basically makes us being interested to look at higher magnification images. And when we go at higher mag, we see that, yes, there are fibrils. There are many fibrils, numerous fibrils that are haphazardly arranged. They're not branching. They're not showing basically periodicity. And that's correct. I mean, the marks were on fibrils. And when we measured those fibrils, many of those, the average diameter was 9 nanometer, and with a very small standard deviation, less than 1 nanometer standard deviation. Okay, so there are many fibrils, numerous fibrils, haphazardly arranged. Average diameter is 9 nanometer. Is that widespread? Yes. In other regions, we see the same thing. Here, by the way, I mean, we see a neutrophil, and this is a mesangial cell. So in the mesangial matrix, we see all these fibrils that at this magnification are vague, but when you go a little bit higher in magnification, you can see that there are many, many of them, and they are similar, very similar in size and uniform in size. And also, this is an arteriole or a small interlobular artery, I have to say, because I see some elastic fibers here, as you can notice, or it's a transitional vessel. And these are smooth muscle cells. So when we look at the matrix, the extracellular matrix of this vessel, also we can see identical fibrils. Again, they're uniform in size, and the average is around 9 nanometer. All right, okay. So interesting. We found that, okay, there's some fibrillary deposits, and earlier we saw that there was this IgG lambda staining by immunofluorescence microscopy. So at this point, what is your differential diagnosis? Is it primary amyloid, non-primary amyloid, fibrillary glomerulonephritis, immunotactoid glomerulopathy, cryo, or HCV-related immune complex? Primary amyloid, fibrillary glomerulonephritis. Because of that, I think that both of those could be in the differential. They're reasonable because, I mean, we'll talk about the size actually. I mean, I wish that to include one more that wasn't in the initial slide, and that was type 3 collagen glomerulopathy. I mean, all of those, except for cryo that has substructure, they have fibrillary deposits of various sizes. So if we go by the fibril size, this is the common range for the fibril size. So for the primary amyloid, you say that, okay, 8 to 12 nanometer. Doesn't matter whether it's primary or non-primary. For amyloid, it's about 8 to 12. For fibrillary, it's a little bit on the thicker side, so 12 to 24. But actually, I mean, in our hand here, I will show you that the range of fibrillary glomerulonephritis fibers is actually, I mean, wider, and they can be thinner than this. Immunotactic is 30 to 50 nanometer, cryo can have substructure, and type 3 collagen is 60 nanometer. Okay, so what study at this point do you want to do next? And again, you can choose as many as you want. Congo-Red to confirm your diagnosis of amyloid, DNA JB9, IgG subtyping, pronase immunofluorescence on peripheral sections, mass spectrometry, or collagen stain. And as I said, you can choose as many as you wish. Congo-Red, of course, we want to do that. DNA JB9, yes, we want to do that because we have IgG, although, I mean, it looked like it's monotypical, but fibrillary is definitely when you have IgGs in your differential. Pronase immunofluorescence, of course, we have to do that, and we'll talk a little bit more maybe about that. Nobody wants to do IgG subtyping. Okay, so I put a mark there because definitely I want to confirm whether the deposits were monotypic or not in using different aspects. So mass spec is also a very good choice, but I would do pretty much all of them. Or if I get a very clean answer, maybe I can forego with mass spec depending on, you know, how available that is going to me. So I add IgG subtyping here as well. So let's see. Let's start with Congo-Red and DNA JB9. For some reason, I think, no, but you guys can see, right? Yes, yeah, you can read. Congo-Red, as you see, was negative. DNA JB9 was strongly positive in the deposits. Okay, so the questions, please answer to the questions below. Is amyloidosis ruled out? Is fibrillary glomerulonephritis confirmed? Congo-Red is negative, amyloid is ruled out, fibrillary glomerulonephritis is confirmed. Okay, I like both of these answers because DNA JB9 is very sensitive and very specific for fibrillary, and Congo-Red is part of the current definition for amyloid. So I like both of those. And by the way, when we did DNA JB9, we also had focal vascular staining, which is something that we can see in fibrillary, but that it cannot differentiate that from amyloid because we can see that in amyloid as well. Now, if both Congo-Red and DNA JB9 were to be positive, which one is true? The diagnosis is amyloidosis. The diagnosis is fibrillary glomerulonephritis. The diagnosis is mixed amyloid and fibrillary glomerulonephritis. In our case, Congo-Red was negative, but just imagine that if Congo-Red was positive, DNA JB9 was positive as well. Okay, the diagnosis is fibrillary GN. Yes, yeah, I like that. I like that very much. And you're correct. As I said, DNA JB9 is very specific, and about 5% of fibrillary GN cases are indeed congruent positive as well. But it's not the other way around for amyloid. So the way that we're currently classifying these are this way. So even if congruent positive, as long as DNA JB9 is positive, we're going to call it fibrillary GN. And that is confirmed by mass spec as well. So fibrillary glomerulonephritis, as I said, I mean, one question could be that, okay, I mean, what about the fibril size here? Because I showed you 9 nanometer, and that 9 nanometer was, in the range of amyloid rather than fibrillary that you commonly find. But indeed, basically, a study that, many of us were part of that, and Kelly was the senior author, and Nicole was the first author. As you can see, something that is relevant to our case is that the median fibril diameter, the full range, was 9 to 25. And indeed, about 6% of the cases that were studied here, the fibril diameter was 10 nanometer or less. So in fibrillary glomerulonephritis, although commonly it is, as I showed you, it's a little bit thicker than amyloid, but really it can be, on the thin size as well. All right, okay, fibrillary GN. But is that a monotypic fibrillary GN? Because I have showed IgG lambda. But is it really monotypic? So as you know, I mean, monotypic fibrillary GN is super rare. Fibrillary GN can be monotypic, but in true monotypic is less than 1%. And because of that, it is highly recommended that you need to confirm that. When you see that by regular immunofluorescence, you have to confirm that it's not like, masked deposits. So we have to actually do IgG subtyping. We have to do pronase digestion, especially immunofluorescence microscopy. And also, if you want to do a little bit fancier thing, using immunoglobulin, heavy chain, and light chain to confirm if the deposits are indeed monotypic or not. So we didn't have the latter option, which is fancier, but we did IgG subtyping and pronase digestion immunofluorescence microscopy. As you see here, for IgG subtyping, IgG1 is the strongest, but also it's staining for the deposits. We're staining for IgG2 and IgG4. And therefore, IgG subtyping does not confirm that the deposits were monotypic. What about pronase digestion immunofluorescence microscopy? As you can see, also this one shows that the deposits are staining for IgG, kappa, and lambda light chain. So pronase digestion also is not supportive of monotypic fibrillary GM in this case. All right. Okay. So then, what is going on? So we of course, I mean, we have some information. Well, we don't have all information about the donor, but looking at the conditions associated with fibrillary GN, malignancies, yes, monoclonal gammopathy, autoimmune diseases, hepatitis C, diabetes, hypertension, immune checkpoint inhibitor therapy rarely has been rare reports. Even COVID-19 has been reported. And they could be idiopathic. In this case, we had hepatitis C, and also the patient was diabetic as well. I assume hypertensive too. So multiple risk factors for having fibrillary GN. So that at this point, we believe that is the most likely, in fact, scenario that has happened. Has this rare thing, donor-derived fibrillary GN, been reported in the past? So there is only one unpublished or partially published report. I mean, as a case that was presented at ASN in 2021 from UC Davis. That I've posted the case description here. So that was in a 73-year-old female related basically with end-stage kidney, secondary to ANCA glomerulonephritis. who receives a preemptive deceased donor transplant from a 62-year-old 79% kidney donor profile index female. The patient experiences slow graft function and native serum creatinine of 1.7 at month 4 post-transplant. And after that, the creatinine stabilizes in the 2 to 2.3 range. Proteinuria was fluctuating between 1 to 2 gram per day. Time zero biopsies showed mesangial widening, similar to our case, some hypercellularity, some double contours. We didn't have that. And DNA JB9 was positive. And interestingly, in that case, also the deposits were kappa light chain restriction. There's nothing saying in that report that if they did IgG subtyping or protease digestion. So they didn't. But actually, I contacted them, and I think that the plan is to write these cases up, and we have to do protease digestion immunofluorescence. That's something that we can do on that case as well. But 4-month surveillance biopsy showed similar findings. So the fibrils were still there after 4 months. Background renal parenchyma showed moderate chronicity and prominent chronic vascular disease. At 10-month post-transplant, creatinine remained in the same range, and proteinuria also remained in the same range. How is it going to be in the longer term? As you know, I mean, when we have the deposits in the mesangial matrix and in the glomerular basement membrane, at least we know that the turnover of the components in the collagen in the glomerular basement membrane and mesangial matrix is really, really long. But how about when we have the fibrils of fibrillary GN? We don't know. So in that case, at least we know that there was this 4-month persistence of fibrillary GN. So any questions about this case? Any discussions before we move on?
Would you like an update from after the biopsy? Did you have the other slide that you'd like me to show?
Oh, yes. Yeah. Let me see if I missed to put that. Yeah. Okay. So
maybe I can just briefly summarize that while you pull it up. I first wanted to acknowledge that Dr. Kling, like some of our surgeons, do time zero biopsies. And it was very helpful in this case, like usual, to have this data. We now have been doing hepatitis C NAT positive donors for over a year, have done 18 in the first three quarters of this year. That's about 8% of our donors. So this hepatitis C was a 1A genotype. And as you can see in the post-transplant follow-up for this patient, he had delayed graft function, was on dialysis for approximately a month. You'll note his hepatitis C titers rose to above 33,000 IU before starting Mavorite and has since become undetectable. And with that has had a slow graft recovery. Saw him on Wednesday, and his creatinine is down around 4 from an initial high of above 10. And he actually has one of the 2 kidneys from the same donor. We also transplanted the other kidney into another recipient who has very much the same comorbidities as this recipient. And that recipient has a creatinine about 3. That person's hepatitis C treatment was delayed for over a month and is now been able to achieve a marked positive decline in hepatitis C in the last week since starting treatment. So we'll be interested to see how this patient continues to recover. I don't know if you have one more button to push on this slide, Behzad, but I did pull up the UA from this patient's most recent labs, and he has still about 0.9 grams of proteinuria and at least 2 to 3 plus RBCs. That's in the setting of his stent still being in place, which was removed on Wednesday. Thank you.
Okay, thanks, Chris. So do we know that if the other the person who received the other kidney has had any biopsy? Is it here, the other recipient?
The other recipient is here. Neither have had a post-transplant biopsy, in part because I had this knowledge going forward, and we have seen slow recovery.
Yeah. Okay. Okay. Any question?
All right.
All right. So if not, let's go back to our slide deck and okay.
Okay.
All right.
I think
Yes.
I'm up. Okay, great. Hi, good morning, everyone. All right, so this is a case that I was going to present a couple weeks back, maybe a month back, but it's actually better because I have a little more updated information now. But we start back in 2019. So this is a 39-year-old man. He came to kidney clinic for a progressive rise in creatinine over 2 years. He didn't notice any hematuria or foamy or brown urine. He does take Advil about once per week, no kidney stones, but did note some occasional back and flank pain. Didn't have really much in the way of systemic symptoms, so no hemoptysis, nosebleed, sinus disease, synovitis. I won't read all the rest of them, but really nothing else to guide us into one particular diagnosis. He had no family history of kidney disease, autoimmune disease, or hearing loss. And so on exam, a tall, muscular gentleman had some tenderness around his costovertebral areas. His urinalysis showed a 2+ protein, 2+ blood, 14 RBCs, 2 WBCs. I will say that this was not my microscopy. This was the person who saw him at that point. But he did have innumerable dysmorphic RBCs with occasional red cell cast seen. So I'm sure everyone was called in to the microscope to view those. And then 1 year ago, which was the last time he had had urinalysis prior to this presentation, he was noted to have 3+ protein and 3+ blood with 29 RBCs and a couple of WBCs. So it seemed like this process had been going on for some time. He had a urine albumin to creatinine ratio of 1,300 milligrams per gram and a UPCR of 1.7 grams per gram. He had an initial serologic workup that was essentially negative. So normal C3, C4, negative ANCA, HIV, hepatitis was negative. So before we go to his biopsy, feel free to just throw some things in the chat. Oh, or choose, so you don't even have to write the whole word. Just choose A, B, C, D, or E. You can annotate too if you prefer. I'm gonna need to see better than this before we move on.
Okay.
All right, go for it.
All right. So yeah, Alport, IgA nephropathy, more IgA, but a couple of Alports as well. The hematuria, proteinuria. Yeah. Okay. So for this case, actually, I'm Roberto Nicosia, so because I'm presenting on Roberto's behalf. He was away, but it's his case. So I do my best to do a good job presenting Roberto's case. So for the light microscopy, in this case, we had focal global glomerulosclerosis, which involved about 30 to 40% of the glomeruli. It was a pretty good sample with 29 to 32 glomeruli per level section, but as you can see, pretty decent chronic injury, at least on the moderate side. Also, there was focal and segmental glomerulosclerosis involving 10 to 21% of the glomeruli. There was diffuse mesangial expansion with increased hypercellularity, and I apologize that I'm doing the text because I don't have all the images from this initial biopsy that was done in 2019. And also there was segmental thickening of the capillary walls with segmental duplication of the glomerular basal membrane with segmental endocapillary hypercellularity, at least in one glomerulus and one cellular crescent or incipient. Crescent that was moving to a little bit of chronicity with a fibrous component. There was decent, moderate tubular atrophy and interstitial fibrosis as well in the renal parenchyma, and focal mild arterial hydronephrosis. So one glomerulus, it's not from that case, but similar findings. So as you can see, segmental scarring in this region with obliteration of capillary loops and adhesion to Bowman's capsule. Also here we have that with Bowman's capsule reaction, and we have mesangial hypercellularity as well. So mesangial hypercellularity, focal endocapillary hypercellularity. So it looks like, I mean, there is some glomerulonephritis going on with focal crescent formation. And by immunofluorescence microscopy, what you guys thought about IgA nephropathy was correct. I mean, there was 223 plus, predominantly mesangial staining for IgA. There was also trace to 1 plus staining for IgG, and 1 to 2 plus staining for kappa, and 1 plus staining for lambda lichens. And segmental peripheral capillary wall staining in some of the glomeruli, not in all of them. Okay. All right, so now let's look at the electron microscopy. So again, let me choose the laser point. Okay, here. So for orientation, I walk my laser point over the glomerular base and membranes, mesangial regions, and as you can see, mesangial regions are somewhat thickened. When we look at the podocytes on the outside, also you see that there is a fair amount of food process widening, food process effacement, and maybe in some areas we have some microvillus transformation as well, but no obvious subepithelial deposits. Okay, so let's look at the mesangial regions and other parts at higher magnification. So could you please mark the immune type deposits in these images? So again, a capillary loop here, another capillary loop here, glomerular base and membranes, podocytes, and exactly these are the immune type deposits that predominantly are in the mesangial region, or rather paramesangial region, which means that the mesangial matrix attaching to the mesangial glomerular base and membrane. All right, okay. Also, we had segmentally, as you saw by immunofluorescence microscopy, there was segmental peripheral capillary wall staining, and concordant with that, we had some subendothelial deposits. So as you can see, this is the capillary lumen and endothelial cells, and you can say that because you see the fenestration and it's directly touching the lumen. So this is endothelial cells. So these deposits are subendothelial, and these subendothelial deposits are the ones that hurt the endothelial cells. They attract the inflammatory influx and cause endocapillary hypercellularity, and if that inflammation is severe, can lead to the rupture of the glomerular base and membrane and crescent formation and necrosis. And we also had mesangial deposits as well. Okay, so the final diagnosis for the initial biopsy was IgA nephropathy with diffuse mesangial hypercellularity, focal endocapillary hypercellularity. So by MESA score M1 for mesangial hypercellularity being diffuse, for endocapillary hypercellularity E1, for segmental scarring S1, and T1 as there was moderate tubular atrophy and interstitial fibrosis, but it wasn't still severe, and C1 because it said one glomerulus had crescent. Okay, so everything was 1 for MESA score, IgA nephropathy. And now Sarah continues.
Yeah, I will say he was not my patient at this point, but later became my patient because he lives really far away and it was hard for him to get to clinic. So a lot of his appointments were phone and video. But he was started on lisinopril, titrated up to maximum dosing. He had been taking those NSAIDs, so that was stopped. And his UPCR actually improved to about 500 milligrams per gram. His creatinine was pretty stable at 1.5 at that time. However, pretty soon after this diagnosis, he had his very first gout attack, first time he'd ever had one. And he subsequently, every 6 months kept having like pretty severe episodes of gout for which he went to an ER, an outside hospital. He would receive treatment generally with prednisone for a short course. And then he was also started on allopurinol and lisinopril, subsequently changed to losartan started on allopurinol. His lisinopril was changed to losartan for the uric effects. And then you can see that, or actually before we get to the present, closer to the present day, between 2020 and 2022, his creatinine was stable-ish, but progressing at a creatinine of 1.7 to 1.9. UPCR was running between 0.6 to 1 gram per gram. And then more recently, in the last couple of years, his creatinine continued to rise. So I took over care around this time, started him on empagliflozin, which did improve his proteinuria, but his creatinine kept rising to July of 2024, when he was really getting, close to this 20 to 25 mil per minute GFR. And so at this point, given that we had more therapies available for IgA nephropathy, and I was really trying to figure out how much of this was chronicity versus activity or something else completely that I just didn't understand. This seemed quite rapid. He got another biopsy.
Okay, all right. So I don't know if anyone can help me, because I forgot to anonymize the annotations, and I don't know how to do it here.
They haven't been anonymized the whole time, Bazad, and people are still participating, so I think you're okay.
Yeah, I think that we are fine. Okay, all right. So let's continue. So this is the second biopsy that was done, and as you can see, I mean, nice biopsy core. Still significant chronic injury. We had 21 to 26 glomeruli, and this time it's even more of them are globally sclerosed. As you can see, about 60% of them were globally sclerosed. Still, we had segmental scarring. 2 glomeruli had segmental sclerosis, corresponding to about 7%. Mesangial expansion was mild, less prominent than the initial biopsy, and no obvious active lesions. And when we say that no obvious active lesions, predominantly we mean endocapillary hypercellularity, necrosis, or cellular or fibrocellular crescents. And interstitial fibrosis and tubular atrophy, if you remember, in the prior biopsy, it was T1. It was kind of in the moderate side, and now we have in the moderate to severe interstitial fibrosis and tubular atrophy. So there is interval progression of chronic injury in the tubular interstitium as well. So in these regions, as you can see. So and also, I mean, before moving to the other side, I would like to grab your attention that, as you can see in the non-scarred tubules, also we see kind of like hypertrophic changes. I think we have a better view of that in the next slide. So this is one of the glomeruli, and like in the first case, that we talked about mesangial hypercellularity. We want to see 4 or more nuclei, and certainly this one in this segment has about 5 or 6 mesangial nuclei. So there was focal mesangial hypercellularity, but less prominent than the initial one. Yes, so this is a higher magnification. Still, we had segmental sclerosis or scarring with obliteration of capillary loop and also focal deposition of hyaline. Maybe very limited influx of leukocytes in the glomerular capillaries. A lot of chronic injury with tubular atrophy and interstitial fibrosis. And yes, I mean, this is what I wanted to show you. So here we have a better picture. The rest of the tubules, they show some hypertrophic changes, which is also reflectant of widespread progression in the chronic injury. But this time, we also, basically the sample included good amount of medulla as well, and we had a new finding. So what are these lesions that we are seeing here? Oxalate crystals, calcium phosphate, cholesterol emboli, tophi, or sarcoid granulomas. Cholesterol emboli and tophi. All right. Okay. Well, sometimes it can be a little bit tricky, but let's go over the findings. All right. So this is medulla, right? So the vessels that in the medulla we have, unless if we move towards the hilus of the kidney, are predominantly either are capillaries or they are vasorectal. So I mean, that is the size of the vessel. We're not talking about interlobular arteries, those kind of things, or arterioles. Vasorectal are okay, and you know, typically they have low pressure in them. So in this region, what we are seeing, in fact, are, as you can see, we have these kind of like the crystal clefts, because I mean the crystal themselves are kind of removed, and then around them we have these cellular, maybe syncytial cellular or giant cell reaction. Here it looks kind of like a granuloma. And you look at here, I forgot to actually, I mean, this can be like a, I don't know, pigeon. If you look at it, right? So feathery crystals. So if you think about a pigeon, you hopefully will remember that. So feathery crystals engulfed by the giant cell reaction in different places. And here you can see a little bit finer feathery reaction. And around that, we have inflammation. The classical is that inflammation is histiocytic, also has lymphocytes, can have plasma cells as well. And those features are typical of tophi. And when we're talking about the cholesterol emboli, we're saying emboli. So that means that we need to see them predominantly, I mean, in the vessels that they have like media, smooth muscle cells in the arteries or arterial. So that's, but sometimes I agree. I mean, sometimes we have cholesterol clefts in the tubules, and around the tubules, we have reaction, which may make it a little bit difficult to tell apart between those two conditions. But these are tophi, and we have more of them. As you can see, there were a good number of those. Again, kind of feathery crystal or crystal clefts, better saying. And this is very typical of urate crystals. As you know, I mean, it is dissolved. If we want to see the urate crystals, you need to fix the tissue in alcohol. Otherwise, it will be dissolved, and it is dissolved here. But the features, feathery crystal clefts, giant cell reaction around them, kind of like granuloma, and inflammation surrounding them. So we had multiple tophi in the biopsy. Immunofluorescence microscopy, very prominent chronic injuries, so 6 to 7 glomeruli, 4 to 5 of which were globally sclerosed. So not many glomeruli to look at to begin with. Focal and segmental staining for C3 that we see in segmental sclerosis. There was no significant staining for the other immunoreactants, including IgA, which was kind of like surprising. I mean, with the caveat that the number of patent glomeruli were quite limited. However, I mean, that was kind of a surprise, and therefore immunohistochemistry was performed for IgA. And it showed high background, and for sure. I mean, when we have a scarring, typically also we see higher background as well. And if the glomeruli had segmental sclerosis, also we see more background, and it makes it more difficult. But no specific staining, no strong staining in the glomeruli for IgA, which was, I suppose, kind of like surprising as well. So final diagnosis for that case. So again, very beautiful, feathery crystals, giant cell reactions around them and inflammation. Was extensive global glomerulosclerosis with focal segmental glomerulosclerosis or scarring. It's likely, I mean, secondary to the IgA that this patient has had in the past, and moderate to severe tubular atrophy and interstitial fibrosis, and chronic uric acid nephropathy or gouty nephropathy with arteriolar hydinosis. Okay, so now we hear the follow-up from Sarah.
Yeah, so I will say that Dr. Nicosia had called with that biopsy result, and it was just very surprised by the lack of IgA deposits, and asked me, what did you treat him with? And the answer really was nothing, except of course he kept receiving these, short steroid courses for his gout kind of through this time. So I didn't send electron microscopy on this biopsy because really I was trying to look for activity and chronicity, and so sent the majority for light and some for IF. So we didn't have that data, but at least it was interesting that there were no IgA deposits on this repeat biopsy. Other surprising fact were all these uric acid crystals. So looking back, as far as we had data for, his uric acid levels have been really high for some time, even when his creatinine was more in the 1.5 range. And he didn't, again, start having these gout attacks until later in 2020. But you can see that the majority of really, at least over 8, some as high as 13. On the day of biopsy, his creatinine was 3.1. So his GFR was right about 20 at this point. So he was already on allopurinol. I added febuxostat, which is another non-purine xanthine oxidase inhibitor that doesn't usually have to be used in combination, but in this case, I was treating him as if he had tophaceous gout, and so was really targeting uric acid less than 5. And now I have a little bit of follow-up information. So, oops, one backward if you can. So in mid-October, his uric acid was 4.2. His creatinine came down to 2.2, and I don't have another value to prove that this is real and will continue to stay low, but I was quite pleased because he hadn't had a value that low for about a year now. So that was encouraging. And he was also very excited that his GFR improved significantly. And so I say this not to advocate for like universal uric acid lowering therapy for all patients with chronic kidney disease, because we know that that doesn't work. In fact, there are 3 RCTs to show that that doesn't decrease progression of chronic kidney disease. One in type 1 diabetes, for which Ian was involved in, another in patients with stage 3 and stage 4 chronic kidney disease, and even another specifically looking at febuxostat in place of allopurinol. I will say that I think what these studies did show us was the safety of the use of both allopurinol and febuxostat in patients with CKD stage 3 and stage 4. He and all of these trials also excluded people who had gout. So obviously in people with gout, you have another indication for treatment. This was really just trying to target patients who had chronic kidney disease to see if there was any benefit. And then Basad, one more slide. All right, so this is just interesting. And again, not making any, big conclusions based on this, but I did find this one trial, one cohort study that I found interesting, that in a group of patients that were followed over 7 years, looking at uric acid levels who had IgA nephropathy, people who are in the highest quartile of uric acid did have a faster, a higher rate of the primary outcome of death or 40% decline in eGFR. So just something that I found interesting, but nothing that, something that maybe needs further study. So that is a little happy story to end our biopsy conference this morning.
Thank you, Sarah. So yeah, I saw this study as well. And there are a few other ones that are also suggest that that the patients who have hyperuricemia, maybe they progress faster with IgA. So, but it is not like a well-confirmed concept, as I'm hearing from you, right?
Right. And even if it does, it doesn't mean that treating the uric acid is actually going to help. like
Yes,
many things in nephrology. Just because there's an association doesn't mean that acting upon it is going to lead to a better outcome. So again, just out of interest, because it was interesting that he had the IgA nephropathy and then developed all this severe gout and improved with therapy.
That's very nice. I have to say that, I mean, not commonly, of course. I mean, rarely. And in patients that we have multiple biopsies from patients with IgA nephropathy, sometimes I mean, clinically you see sometimes regression, and we see sometimes disappearance of IgA deposits or significant reduction in the IgA deposits as well. But there are smaller. I found one study that was done a few years ago that they had biopsied patients, rebiopsied patients who were with IgA nephropathy who were clinically in remission. And what they found in average follow-up, I think, was something like 35 months. And what they found was that, in about a quarter of them, the deposits were reduced, or in some of them, the deposits were just disappeared. The ones that clinically they were in remission of IgA.
Yeah, and actually that's a nice point, because in this study they did try to adjust for treatment, but obviously that's hard. So
questions and comments?
So we have a question in the chat from Galuan. For the first case, just to clarify, it's non-monotypic fibrillary GN caused by Hep C virus infection.
So the answer is that correct, based on the pronase digestion immunofluorescence and IgG subtyping, based on both those studies that are highly recommended to do actually in fibrillary GN, that by regular immunofluorescence they look monotypic. Both of those ruled out a monotypic deposition process. So we believe that yes, the deposits were not monotypic indeed. They were masked deposits of kappa.
Hi, this is Bilal. Question for Sarah. Sarah, with consideration for this young man who's probably looking at transplant in his lifetime, any consideration for like AD-TKD things like UMOD, MUC1, HNF1 genetic mutations, which can probably be associated with such high degree of hyperuricemia?
yeah, no, that's a really good point. And so I was looking into that as well. Luckily, he's a little bit better in terms of his GFR right now, but I think it would be worth looking at that prior to transplant. He didn't have any features necessarily on biopsy of like tubular interstitial disease on that first biopsy that wasn't associated with the IgA, but I think that's a very good point to bring up. Brendan, I don't know if you want to comment on that.
I would agree with you, other than maybe the transplant people can pipe into just in a lot of young people. I think the more, just the random young person with kidney failure, there's more use of genetic testing broadly, but for transplant patients, I mean, transplant candidates. But I agree with the specific features that would make you think of UMOD, other than the gout was sort of later, after this CKD was well progressed. I don't know.
Okay.
All right.
If there are no further questions or comments, maybe we can adjourn here.
All right. Yeah, we're at 9:30. Thank you, everyone, for a very good conference today, and we'll see you guys back again next week.
Thanks, Danny.
Thank you.